Irene, you want to give it a shot?
Okay, so hi everyone. My name is Irene, and I'm really excited and grateful that I'm here today to present. Is this one not working? Thank you. So I'm really grateful and excited to be here on behalf of the Dutch ALD Research Group. And I will give two talks. One is today. It's a little bit shorter than tomorrow, so today is just going to be a brief introduction on some of our ALD efforts, but also our view on the disease. And tomorrow I will elaborate a little bit more in depth on what we are doing, some preliminary results, and I'll introduce the clinical care pathway that I already talked about just now. Do we have a... So before I start with my introduction, just a small other question. Have any of you actually been to the Netherlands? Could you raise your hand? Oh, that's quite a lot. I hope you guys liked it. I think it's a beautiful, although tiny country. We have about 17 million people that live there, so that's not a lot. And did you guys visit Amsterdam? Probably, yeah. So, of course, yeah. I brought tons, yeah, for everyone. Because that's all we do essentially. We wear wooden shoes, we eat raw fish, and we smoke weed all day. So this is the Academic Medical Center. This is where the Dutch ALD Research Group is located. More than 8,000 people work there, and it doesn't only house the university hospital, but also the Faculty of Medicine of the University of Amsterdam, the MS Children's Hospital, and some other institutes. This is our research group. So the main goal of our research group is to understand disease pathogenesis, to develop predictive biomarkers, and to translate this knowledge into a platform that helps towards effective treatments. And it's just a small group, but what I think is the real strength of this group is that the basic scientists and the doctors work close together under one roof. And my role in this research group is that I'm currently doing a PhD in ALD, so I focus only on ALD research. I do clinical research together with Mark Engelen, and Stefan Kemp helps us with all our lab work. So all of you know, of course, that ALD started out as this brain white matter disorder with adrenal failure in young boys. And it wasn't until later that also reports from adults with this hereditary form of spinal cord disease and adrenal failure started to appear. And it wasn't until the discovery of the biomarker, of course, these very long-chain fatty acids, that it would become clear that these disorders belong to the same clinical spectrum characterized by these very long-chain fatty acid accumulations. So after that, the clinical characterization was really expanded. So you didn't only have childhood cerebral ALD, but also adolescent cerebral ALD, adult cerebral ALD, adolescent only. Well, of course, you guys know the work, so you know it. And for a long time, we have been dividing ALD in a disease with distinct phenotypes. But now, if we look back, then the name adrenoleukodystrophy might be a little bit a misnomer, because not all patients have adrenal disease or cerebral disease, especially women. So ABCD1 deficiency or ABCD1 deficiency syndrome might be better. ALD. We assume that patients are born pre-symptomatic. And you all know that boys usually present with adrenal insufficiency, and later on in life they develop a myelopathy. And cerebral disease can manifest either in childhood or adulthood. In women, Adrenal and cerebral disease are considered very rare, but they do often develop symptoms due to myelopathy, so that's spinal cord disease. And the chances of getting symptoms increases with age. So we should really consider ALD a progressive metabolic disorder. So this is a slide that I think everyone will know, so we'll go through really fast. If anyone has adrenal insufficiency, we can give replacement therapy. If there's a myelopathy, we only have symptomatic treatment so far. And if there's cerebral ALD, of course, we can give a bone marrow transplant. And well, most people will know this slide, but I just want to introduce it for maybe some of the people that haven't known about ALD for such a long time, because this is the slide why we think it's so important to keep on making MRIs of children and adults with ALD. Because this is a survival plot. Let's see if this has a pointer, yes. So on the x-axis you can see the years after bone marrow transplant. On the y-axis are the number of patients that are still alive. So, and this is 100% and it goes down. Then we can see two graphs. One states a Lewis score below 10 and the other one 10 or higher. And we already heard the term Lewis score, of course. It tells us how many MRI abnormalities there are. The higher the number, the more MRI abnormalities. And if we look at, for instance, 5 years, you can see that if there are less MRI abnormalities, the prognosis is much better. So, of course, that's why we find it so important to keep on making those MRIs and detecting cerebral disease. I think we'll just skip that because we already saw that. So let's talk research. What are we doing? Firstly, we are also really working on defining natural history because, well, we've heard this today, I think, well, the entire day. It's so important to become ready for clinical trials. We need good outcome measures for disease, especially also for the myelopathy. We need to be able to quantify this. And that's something we're really working on. So I wanted to elaborate more tomorrow, but I'll just say a few things about it for the people that can't make it tomorrow. We're doing several things. We're doing extensive neurological examination. We're using different myelopathy scales, walking tests. But we're also looking at the optical coherence tomography, so that looks at the optic nerve to see if that correlates with disability. And we're doing spinal cord MRIs. So besides that, we're looking at women as well. We're doing a follow-up cohort study, 5 years. So Mark saw them 5 years ago, and now we're seeing everyone again to see how everyone's doing and to be able to know more about the progress of disease, if it progresses, and if it does, how fast. Then phenotype prediction. We want to be able to detect or predict cerebral ALD earlier. More and more patients with ALD are being detected each year. And for boys, this means that they enter this spiral of MRI follow-up. And this is a huge burden. And besides being a huge burden, it's really not efficient. We have to be able to stratify who are high-risk patients, who are low-risk patients. And we are doing this by conducting a longitudinal study, and we're right in the middle of it. It's 3 visits. We're in the middle of visit 2, and we do an extensive follow-up. So we do a long MRI, we do blood work, we look at cerebrospinal fluid, and we hope that we're going to find some biomarkers that are going to help us. And lastly, the development of a clinical care pathway. I think the need for standardized clinical care has become very clear. We need to do this. It's a lot of work, and that's why we have to work together. We have to collaborate, and we have to make this international so it will get implemented even better. And it's not only for the patients that it helps to clarify disease process, but it helps doctors to be able to give evidence-based treatment, and it helps insurance companies to professionalize care. We can't do this without the patients. So far, we've seen 50 boys and men. The youngest was 3, the oldest one was 71, and 48 women. And what really helps is that Mark Engele is not only a child neurologist, but also an adult neurologist, so we can see all the patients. And these numbers keep on counting. And what does it mean to be in our studies? Because we are asking quite a lot of our patients, and they've been the best. So I want to take you through the day of one of our study patients. So say we have a male patient who participates in all of our studies. This would be the study day. So the patient would arrive at 9 a.m. We would do the appropriate paperwork, some blood sampling, then a neuropsychological assessment for 2 hours, endocrinological checkup, small break, extensive neurological evaluation in which we do all those myelopathy scales and walking tests. Then an eye evaluation for 3 hours. And that takes that long because you have to test eye per eye. And we do all different kinds of tests to evaluate the optic nerve. Another small break, then an MRI, takes an hour and a half. And lastly, but not least, the lumbar puncture. So this is from 9 a.m. in the morning until 7:30 at night. So this is really substantial. The women, they have a little bit of a shorter program. They only do the neurological evaluation and the eye evaluation. But it's still quite some hours that they spend in our center. So I hope the next years to be able to come here again and then, of course, have an improved prospective definition of natural history, to have been able to identify a prognostic biomarker, and of course that we've all together implemented a clinical patient care pathway. Thank you so much.
You mentioned earlier on about the distinction between high risk and low risk, and is that you meaning to entail sort of those with a propensity to develop the cerebral form versus those that don't, so that kind of predictive element, which
Yes.
is kind of like the great frontier. And is there a risk? Could you just describe a little bit more about how you're attempting to develop that understanding? The methods?
So what we're doing for the predictive biomarkers is that we're following this cohort prospectively, and we're doing the extensive MRI, the blood work, the CSF, and we're going to use, for instance, an omics method. We heard more about that today. So we're doing lipidomics, and I'll present tomorrow some of our, actually the very first experiment we've done, the results. And this is a technique that you can measure tons and tons of lipids, and we want to see if we can use that to identify new markers that will predict disease. But it's going to be like we follow them, we look who gets cerebral disease, and then we look back. Could we've noticed earlier? And then of course you have to validate the markers, and it's going to take a while.
How would this information be used in a practical sense? You mentioned something about MRIs. Would it be like, oh, you're a low risk, so you need less MRIs? Is that what we're talking about? Yeah,
that's what we're hoping, that if we find a marker, that we would be able to say, at birth, if you're detected at birth, that we measure whatever in blood or we make an MRI, and we can tell you, oh, you're a low-risk patient, so you don't have to come every 6 months for an MRI. You can come every 2 years. That's our hope. Yeah. And that the high-risk patient that we could maybe even think about treating them. Yep. Any other questions? All right, thank you.
Great. Thanks so much, Irene. That was really wonderful. So that's a really nice overview of kind of the soup to nuts take on where ALD care is and where we and the next steps in getting it to kind of better outcomes. So,